All right, welcome everyone. Thank you for attending. My name is Kimra Stout, and I am the Project Manager of Training and Development with TEFI. Welcome to the TEFI, Texas Epidemic Public Health Institute Grand Round Series. Today, our guest panelists will be speaking on lessons learned from COVID and local public health response to emerging infectious diseases. Please direct your questions to the Q&A section, and we'll ask those after the presentation. Before we get started, I want to tell you about our upcoming grand rounds. In January, Dr. Anthony Moreso from Baylor College of Medicine will be talking about wastewater. And in March, Chris Frederigill, who is the Director of Mosquito and Vector Control Division at Harris County Public Health, will be speaking on vector-borne diseases. So now let me introduce today's speaker. Dr. Jacqueline Minter, MD, MBA, MPH, is the local health authority and director for the Fort Bend County Health and Human Services Department, a role she assumed amid the pandemic in February of 2020. Dr. Minter has served in the Fort Bend County Health and Human Services Department since June 2017, beginning first as a preventative medicine physician in the tuberculosis program. Prior to her service with Fort Bend County, Minter served in the Harris County Health Department, Texas Department of Health, Texas Medical Foundation, and NASA Marshall Space Flight Center. Dr. Jacqueline Minter is also a public health and general preventative medicine specialist and is board certified in public health and general preventative medicine. Dr. Minter earned a Doctor of Medicine degree from the University of Alabama and a Master of Public Health degree from the University of Texas School of Public Health. Welcome, Dr. Minter.
Well, thank you for the introduction, and thank you so much for inviting me to present. You know, it's interesting. I should have learned the lesson that you shouldn't select a narrow topic when you are presenting your topic 2 or 3 months later. Things change, as we know, rapidly in public health. I feel like they've changed even more rapidly over the past 2.5 to 3 years. So I'm not sure I appreciated how much the landscape would change before I presented today. So I've changed my title slide to lessons learning from COVID. We're still in the pandemic. And so there's lessons that we continue to learn. First, for some background, I am the daughter of a history professor, and my father was born before the Depression, just before the Depression in the late 1930s, 1939 or so, and he came of age in post-World War II America, and he was a young adult in the 1960s, and he has reminded me that history needs time to be made, and it needs time to pass before we can begin to accurately evaluate it and learn from it. And he said, there's a reason they call it the 60s and not 1960, 1963, 1965, 1968. We called it the year 2020, and we said goodbye to it as if it was all going to go away just because the year went away. But we know now that that's not the case. Back in the 60s, in the US, there were assassinations. There certainly was civil unrest, there was war, there was presidential upheaval. And with those societal events, major changes to the health landscape were also occurring. The approval of oral contraceptives, the pill, the passage of Medicaid and Medicare legislation, and yes, a flu pandemic in 1968 that took an estimated 100,000 US lives. Now, my dad said it sometimes felt as if the world was coming to an end with all the anger and the death and the constant change. Does it sound familiar? I'm sure it does. He survived. I just turned 88 this month, and we all will as well. So with that backdrop, I realize it's hard to claim a lesson learned when we're still in the process of learning it. So one of the things I wanted to make sure that I talked about were some lessons from COVID that we as a health department are attempting to apply to future public health events or concurrent health events in real time. There have been numerous articles regarding lessons learned and about the amazing scientific accomplishments, such as vaccine, and some of those seemingly simple feats that are still frustratingly yet to be realized. So I came up with a few themes that I think were impactful in Fort Bend County, and I thought I might share those with you. So first of all, well, I have 4 themes: flexibility, communication, collaboration, and humility. There can be more. There could be maybe one major theme. I think we've talked a lot about communication, talked a lot about health inequities, but those themes seem to be some that we find coming over and over within our health department. And when I talk with others, those seem to be similar themes that have challenged and maybe grown as we go from COVID to addressing monkeypox and even Ebola, flu, other diseases. So I also reviewed, and I say the literature loosely, but I did review some other lessons learned from other articles and other places. And the National Foundation for Infectious Diseases in 2022 had an article that talked about 5 lessons that they felt were learned from COVID. And that was trust, change, scientific literacy, vaccine development, and flexibility. So I thought, okay, I'm kind of, probably in the same realm of what other people are learning and what are some common themes. And there was another article that I thought was hit home for Fort Bend County. And that was out of Yale Medicine Magazine in 2021. And they listed 8 lessons that I absolutely believe we've learned here as well. That masks are useful, that telehealth is becoming the new normal, that vaccines are powerful when they are taken, and there are powerful arguments against them being utilized. Inequities exist. Mental health is important. We are resilient. Community is essential. And I think they added, so is technology, which I think we all can appreciate. And humility is needed. So these are sort of summaries of what I got from 2 articles. And I thought I'd present those because those themes I found helpful for me as I was going through trying to highlight what we've learned. So we'll start with flexibility. And why flexibility first? It's because I think you've got to be ready to change with anything that's emerging, right? It's new. So wherever you were before, you're going to change, and you have to be ready for that. And so the ability to flex and to be nimble is absolutely essential. So the public has lost trust in public health. We've heard that over and over. Many articles have been written about that and highlighted. And I wonder where this loss of trust began. Well, it's probably something that I think people have mentioned before, is that we are the victim of our own success. So invisible achievements, no matter how amazingly successful we are in public health, these achievements, if they're invisible, are subject to be dismissed and ultimately not believed. So outbreaks that didn't become pandemics or epidemics are huge successes, but who knows? People who didn't get lead poisoning and went on to have, great lives and no problems with their intelligence or brain functioning. Well, we don't know. All we know is the other side. Mothers and babies who survived childbirth. It's what we expect as the norm. So we don't really see these as achievements. And this imperceptibility of success is one reason that public health advocates have been attacked so much over masking and other NPIs, non-pharmaceutical interventions during the pandemic. These, and this statement I found in the Washington Post, a Washington Post article in 2022. And we want to also think about where people started to not feel that trust. And so there were some surveys done, and I think this one was done by the Robert Wood Johnson Foundation in 2021. And this survey showed trust in public health groups seemed to be lower. But I kind of like to think, well, is it really low or just lower than maybe we expect? So the respondents were asked in this survey several questions, but the question that I'm highlighting is that in terms of recommendations made to improve health, how much do you trust the recommendations of each of the following groups? So we've got the CDC, local health department, state health department, the Surgeon General, the NIH, FDA, and then the US Department of Health and Human Services. And as you see, there's a kind of a cascading. So it's dark green, and then it's a little bit lighter green. And you see it's kind of cascading in level of how much you trust organizations in this listing. And I wondered, is trust really that low? Because if you trust them a great deal or somewhat, that's not so bad. And when I see this, I see that, we're around 75% for the CDC, over 70% in most areas. And so I don't know that it's not trusting the organizations, but it is maybe lower than we would expect, because we as public health advocates and public health specialists assume that people will trust us more. So if they're not trusting us in public health, who are they trusting? It looks like they're trusting nurses, so 71%, and this is the same study, nurses, 71%, healthcare workers that they know personally, about 70%, and doctors, 67%. So people that they're actually able to touch. And to me, that makes sense, because the CDC, you can't really touch the CDC unless you maybe live in Atlanta or live in one of the locations where the CDC is. And you can't touch the FDA. You can't often touch your local health department, although we're working on that. I think all of us realize that we must do better about that. But you trust people who you see, and healthcare workers, nurses, you see them in clinics. Healthcare workers, they're either your family members, they go to your community events, they're part of an organization that you're part of, they're in your faith community. So you might trust them more because you know them. And doctors, because when you're sick, or any provider, nurse practitioner, these are people that that are giving you health advice. So there was an additional study about trust in federal institutions. And that was in general. There was an article that talked about the change in that trust in the 5 to 6 months after the pandemic had started, and really after the lockdowns, which were significant for so many people, and they should have been. We had a lot of fear with the lockdowns. And then, of course, there was a lot of negative consequences to the lockdowns, which were felt to be necessary to save lives and to save public health, and did their job as far as disease spread. But there were also consequences to that. So there was a change in trust in federal institutions. In the CDC, trust went down. It's funny that in the US Postal Service, trust went up. And then for FEMA, for the Emergency Management Agency, trust went up. And so the change in trust, people didn't like what the messages that the CDC gave, because the CDC gave messages that impacted them personally and impacted many people negatively. Our health department did a survey of those who had most trusted sources of COVID vaccine information. And so actually, I want to say we did and we're ongoing in our surveys of post-vaccination experiences. So we want to know why people come to get vaccinated, where they get their messaging for vaccines from, and what they understand about vaccines. And we've been doing this, or COVID vaccines, and we've been doing this survey for, about 9 months at every one of our outreach events and every one of our clinics. And we found that the most trusted sources for vaccine information about COVID was the Center for Disease Control. And that kind of makes sense. You know, if they decided to come and get a vaccine, then they probably trust the CDC enough to get their information. The second most trusted source were their primary care providers. So that makes sense. Those nurses, nurse practitioners, physicians that they're getting medical care from. And that makes sense. And that goes along with the other slide and the Robert Wood Johnson and Harvard study. And then family and friends. So people who you know, that's who we trust. People who we know, people who we trust. So where does that tie into flexibility? So I think it's major. So because if you plan on fighting a pandemic with tools that require trust, you have to be flexible when you discover that the trust doesn't exist. You also have to be flexible enough to engage, and I might say fully engage, with those you may not fully trust, because you're going to need those people, even those that you don't trust, to help you get a message across. You've got to engage with them and listen to them if they are going to help deliver a message and engage in a practice that will be better for the public's health. So COVID versus monkeypox. What did we learn from COVID that we were able to apply or benefit from in monkeypox? First, we learned that we weren't quickly flexible in our communication strategies. I think we continue to use some of the same strategies over and over, hoping that the public would listen. The same messengers that we trust, we thought the public would trust, even though they were telling us they did. Information continued to be given from less trusted sources, the CDC, health departments, the FDA. Misinformation sometimes was given from more trusted sources, healthcare workers they know, social media nurses and doctors who they don't know, but social media provides a platform where you felt like you knew people, even though you didn't. I don't know if you all recall a group called America's Frontline Doctors. So these were doctors that were giving information that oftentimes was contrary to the information that the CDC was giving. But people chose to trust them, and they were many times very popular on social media. And so people chose to trust them. There was evolving information that was viewed as changing information. And because it was changing information, it was not viewed as trustworthy. We learned that in COVID. What we also learned very quickly is to become flexible with telehealth and remote working. So we knew we had to get things done. When everybody went home, we learned methods like this, and they still continue to communicate with each other and communicate with people in need. So our patients and other people in need. In monkeypox, how did we use what we learned? Well, due to the proximity of COVID, both of them still occurring at the same time, the public was more prepared for changing information, even if sometimes they didn't trust it. They understood that information does change, science information changes. And there's an early target community that had a history of advocating with the public health establishment and governmental agencies. So even if there was some mistrust, there was a community that was affected early on in monkeypox that had history with making sure they engaged with public health establishment. And I think that helped. The trust gained in fighting COVID benefited the efforts to address monkeypox. And we were less baffled by the mistrust and disbelief. I think that really threw the public health establishment we were a little off balance about how much distrust there was in the community. We became very flexible in adjusting our vaccine delivery models. And We allowed telehealth to be rapidly, telehealth allowed testing to be rapidly approved. We had to go through some of the same processes that we did with COVID. And that was kind of distressing, with testing having to be done, it being approved through slow methods. But telehealth allowed us to approve the testing more rapidly because we had videos and we had pictures that we could look at and then send those to the approving agencies so that people could be tested faster. So the lessons we're continuing to learn is that trust must exist before the crisis. And telling people to trust you can sometimes have mixed results. You can't abandon trust in what you know and what we know as professionals and experts, so subject matter experts. But we have to be flexible enough to incorporate new information so that it can be used by the public. So we continue with communication. So that flexibility, that trust, that communication. We cannot underestimate the importance of educating the public about how science works. Not only how and why recommendations change as we learn more, but also why public health recommendations do not change solely on one small study and what it takes to truly vet a study. And we also have to acknowledge that because we haven't done that education, it's going to take time before we see the results of that. We've also learned that it doesn't pay to disparage a struggling partner in the public space. One of our struggling partners was the CDC, but we still needed all of their subject matter expertise, and we do, as we go through monkeypox, Ebola, polio. They are the experts, and when they're struggling, and we have challenges, and we should, when we play that some of our challenges out in the public space, the public becomes more confused and their trust is diminished even further. So we have to be careful about that because there are consequences to that. We have lived now in an era of real time and evolving, and real time like nothing else. I was formerly in this position during 9/11, and it took a lot of time for people to drive out, to interview, to talk to you. You had a chance to think about the questions. You had a chance to correct the answers. There's a very different atmosphere when news was being communicated. And so communicating in real time is very challenging. There's production of scientific knowledge onto the public agenda in real time as it's being discussed and thought about before ideas are fully formed, before ideas are fully vetted onto a population that is not as scientifically educated or nimble. And we should not blame them for that. That's our choice. That's our field. That's what we do. But others are not in that space. News media and commentators analyzed successes and failures of the pandemic in real time. And they called them successes and called them failures in real time. And as I gave the backdrop earlier, it takes time to determine whether something was truly a success or a failure. But when you're making that judgment as the event is happening, it's very challenging. Bringing the process of scientific inquiry, which is fraught with uncertainty, and that is how it is. That is what it should be. When we bring that onto the public agenda and the public space with not just the nightly news, with the daily posts, it's challenging for everyone to make decisions. And we found that uncertainty emerged kind of as that frame in the news coverage of the pandemic. Reporters and commentators were expressing frustration over changing public guidelines, and as new scientific evidence emerged, they lacked the understanding of the process, and that led to this massive politics being involved with the pandemic response in their reporting. So public health commentators or communicators need to be aware and more responsive of the variety of media reporters and the experience that they'll bring. And they're going to have different interpretations with their reporting. So more care and effort are needed in these communication engagements so we can minimize the inconsistencies, uncertainty, and the politics coming into the frame. One of the things that we tried to be more careful to do was to ask people to give us their questions. We understand that they have a deadline, and we understand that news needs to come carefully, but it needs to be accurate. It needs to be thoughtful, and it needs to be, we need to take the time it takes to give good information. And we can share that, and we need to own the space that we share. We have that. We'll give you information. This is what we can give you. This is what we can't give you. But when we have better information, we will provide that. And we definitely got better at that as time went on. When uncertainty messaging goes wrong, the job of the communicator is really to find out which uncertainties are important to the individual and deliver scientifically grounded messages that provide this information. When it goes bad, we get needless hesitation because people might postpone a decision because they're trying to get more information when we haven't let them know that there's uncertainty in their preferences, not necessarily uncertainty in the information that we're giving them. That there's unwarranted confidence. People think that they know themselves and their circumstances better than they actually do. We found people that had so many vulnerabilities that felt like they weren't in the risk category, even though they were obese, over 65, and had high blood pressure and diabetes. They still did not view themselves as being vulnerable and needing to take certain measures to protect themselves from disease. And we saw over and over and over the tragic consequences of that. People would make inappropriate choices, and they may have made better choices if they had a better understanding of the uncertainty. So inappropriate choices to wait when they were sick and to wait even longer when they were really sick and barely breathing, and then they get to a hospital and they're in a situation where it's too late. Personal regret. We saw that over and over. People wished that they had made a different choice, which would have been possible if they had a better understanding of the uncertainties. And then there was interpersonal resentment. People might blame others who they believe should have helped them work through these uncertainties. And there was interpersonal resentment we found with just the differing views. Now, interestingly enough, these 5 areas where uncertainty messaging can go wrong and the consequences of that are not new. These were posed in an article in 2014. And so the article was discussing the benefits and risks of pharmaceutical products. And so, there was a conference and there was this workshop, and they were talking about so many things that we see play out in 2020, 2021 when vaccines came about. So what did we have to do in our health department? Because when we started out, we were very, very small, like many. We didn't have a lot of people. And one of the things we had to do is innovate quickly. So, and we didn't worry a lot about innovating necessarily well. We just were trying to keep up. People wanted information very quickly. They wanted to know about every case. They wanted to know when it was happening. There was a time we were updating 3 times a day. Every time we found out about a new case, we were updating, we were giving information. Then it was twice a day, and then it became once a day. And our partners, our big county partners to the east, were able to give beautiful line lists because they had a lot of people. And we literally had a couple of people. And so one of our partners in the county was working in engineering. And she said, I've seen this thing called a dashboard and a hub. And I think that might help you so that you're not having to update like a line list and figure out how to get it up and post it. And so she helped us develop the dashboard, I think, earlier than anyone else. And it was very rudimentary. It wasn't beautiful. It wasn't special, but it got information out. And so not being afraid to innovate with your communication so that you can respond to the requests and the needs for information that the public has in a way that you can control a little bit better. And how did we pivot that or utilize that with monkeypox is, we thought people are going to want to know. So we weren't in the thousands of cases and sadly thousands of deaths, but we were in the under 10 at the time. But we thought, you know what, we can do this, and that, we can give information. And in case monkeypox becomes a broader issue, well, we've already got our hub ready to go, our platform ready, and we can lead people there and people can get their information. And we felt like that was helpful. Another thing that I think we remembered was AIDS. HIV/AIDS called to mind the harm reduction messaging. And we didn't learn that early on in COVID, but there was in a June Medscape blog by Dr. Monica Gandhi, she mentioned the excellent messaging from the CDC with monkeypox that contrasted with the early abstinence-only messaging that occurred with COVID. And I think we can give COVID some slack because it was so brand new and it came on the scene in a very different way. So we gave very strict messaging early because of that risk communication principle of making sure, it's better to go ahead and give people more stringent guidelines that were needed than not to give them enough stringent guidelines and they would be needed later. And we lost more lives. So harm reduction messaging, which incorporates the needs of individuals while working to minimize the impact of a pathogen, definitely increases the trust in public health and public health messengers. So communication improved. So COVID, we started with a landscape of mistrust nationwide in government, in any government messaging, and this provided a barrier. We had an inability to message uncertainty well. We found that it was easy to damage the credibility of public health by just sowing tiny seeds of doubt. We didn't allow people to identify their needs, but we learned to allow people to do so. As I said, when we couldn't keep up with real time, we had to innovate, and that's when we had the dashboard. And we learned that multiple languages and methods were important for communication. We basically had English and a little bit of Spanish, and that just was not enough. We didn't consider health literacy levels, and we didn't consider, especially in this area, in the greater Houston area, all the different ways that messages needed to be communicated. With monkeypox, we had communication to target communities, and the public was accustomed to what we know at this time messaging. They were, we recognized health inequities early, obviously, and then we increased our health literacy. The public has an outbreak vocabulary after going through COVID, so they understand a little bit more. We had the ability to utilize some of the strategies that worked with COVID in vulnerable populations and those with lower vaccine uptake. And we had a higher index of suspicion for the possibility of the different manifestations of disease that was communicated. We already knew things about, well, this may not be the same monkeypox that has been occurring in years previously. We also, I think, learned not to over communicate. And as I said, we had a simple dashboard initiated early. So collaboration, where are we on that? So collaboration, clearly, we've got old competitors that have become new partners. We need to bridge gaps using that untapped potential that has existed in communication and collaboration gaps. And that occurs between siloed institutions, sometimes within the same industry and across industries. We had to learn to negotiate overlaps. We had to, sometimes you just have to give it to a partner so that you can concentrate on what you need to do. And then we had to create strategic spaces. And these are spaces where we could all come together, where we could be solutions oriented, where we could talk about the things that we were challenged with and then come together to try to develop solutions, maybe for each agency, but not necessarily for every industry or agency uniformly, but new ideas could be shared. And I think that was really great that so many people were willing to come to the table. one of our most successful strategic spaces that was created, that I'm highlighting here, is academia. So the first partner in Fort Bend County that we were able to initiate with was Rice University, and they were able to provide us unbiased policy research on masks, on social distancing, on back to school safety. We were desperate for that. We were small enough that we didn't have a policy arm, and literally, you know, going to meetings and having to speak and not having the time to do the kind of in-depth research I needed to do. And so the Texas Policy Lab at Rice provided so much information on the spot. Sometimes in that real time, I would send them information or send them questions, and they would send me answers within moments before having to speak to school boards or speak to stakeholders or be on calls with elected officials. So it was hugely helpful, and they obviously wanted to help. Another academic partner that was huge and very helpful early on and continued was the University of Houston. We utilized their services with the School of Communication, the Health Communication program, which created a Don't Wait, Vaccinate video. We knew in September of 2020 that we were going to need, the vaccine was coming, and we were going to need to message to populations that might be hesitant. And getting that going in a government space can be challenging to do it as fast as you want to. But when partners step up to the plate and they step up to act, you can do a lot of different things. And so what was created was a mini course was created by one of the professors. And we had students, University of Houston students, create this video for credit. So she taught them about health communication and risk communication and kind of how to produce something fast. And we got a product out of it in record time, and we're able to launch that in, I think, February or March of 2021. And then the University of Houston College of Nursing has been a great partner, but additionally, with being able to vaccinate at our sites, also being able to give us great information that we could share, not just on COVID, but also moving toward other vaccination efforts. So for childhood vaccinations that we're seeing go lower and sometimes lower due to some of the vaccine hesitancy that has been brought about because of COVID. So that partnership has been wonderful. And then the UT School of Public Health. I like to call them our presenting sponsor. Initially, they hosted stakeholder meetings with area health authorities, health department directors, infectious disease specialists from across the region. And they also advocated constantly at the state level. They continue to be a collaborator for health agencies across the state and certainly in our region. And they continue to support us with data. And early on with that modeling, that on each one of the calls, Dr. Burwinkle was there to make sure that we got the latest information of his thoughts. He always gave us, he was so humble about sharing whatever he could with us, whatever would help us in messaging to our stakeholders. So we can't thank the UT School of Public Health Houston enough for being such an amazing partner for Fort Bend County and for the region. Now, a bit about data. I think data inefficiencies were most pronounced in this area, in the area of creating spaces. There were reporting lags early on, interfacing that did not exist at all or didn't work. We had constant data dumps that the public really did not understand, but learned to understand. But initially, it's very hard to message that 99, when we thought that was a lot, or 1,000 or 2,000 or 5,000 or 10,000 cases being reported in a day did not mean that that's how many people had disease that day. There was unclear data integrity, and we are still, unfortunately, relying on the good graces of partners because of certain antiquated rules that don't allow for sharing. We struggle with the fragmentation of health data, of health delivery, and it really shows up in the need for good data that would allow for good reporting, that would allow for faster responses. And that has been incredibly challenging and continues to be. So lastly, I'd like to talk a little bit about occupational humility. So I am going to go back over some of the things that we think about when we think about occupational humility. We know that we've chosen this field, and because we've chosen this field, when there's an emerging infectious disease or any infectious disease, it's what we've researched. It's our life's work. We're passionate about it. And I think that we have to be careful when we express dismay about why the public doesn't believe us or won't just accept what we say. We, I think, at times have been guilty of some occupational arrogance. And I say that because I know personally there were times we were challenged when people would talk about the research they had done. They would use the term research, and we would bristle every time we heard it because it reminded us, that's not research. This is what research is. Well, guess what? They're never going to do that kind of research because that is not the field they chose, but it's what we chose. And if they knew everything we knew, well, would we then be able to think we were so smart? Maybe, maybe not. But we need to realize that for a lot of people, our politician friends, our media friends, their research is what they can do. They can't spend years and in the lab. That is our job. And so we share with them. And when they use certain terms like, well, what I've researched, we just need to broaden our view on that word, knowing that it's separate, knowing that it's not the same, but not being disparaging about that. So when we look at a lot of different, some of the different challenges we've had, we can look at some of the successes that we've had as well. And I think when we step back, have a little bit of patience and take stock of some of the successes we've had in view of where we were with COVID and where we are now, I think that humility helps us see certain things as successes. But when we go over, we had very limited coordinated data sharing. As I said before, we had antiquated data systems. Paper line lists were utilized by untrained staff. We had fax and phone call reporting to people who no longer existed, and personal phone numbers. We had to learn the recognition of the importance of demographic data collection. And then there had to be laws changed in order to do that, in order to force our labs to collect that data. Data security issues constantly were causing barriers with no clear path, and we didn't have funding early, so we couldn't address those. With monkeypox, there's definitely been improved data sharing. Hospitals and public health realized both that it's not perfect and it's still frustrating, but it is much, much better. All 50 states are now able to receive data in an electronic format. So we've updated systems of data collection. It's more seamless processing and reporting through the lab networks and partners. It is frustratingly fragmented, but things are moving in the right direction. The collection of demographic data, still we have to know that depends on cases reporting and people reporting. They have to give information for us to get it. But at least we are collecting it when they provide it. And we have funding for data systems and for data security. The need for disaggregated data continues. We just, had another MOU for aggregated data. People are still have some hesitancy, still have some fear about what de-identified data is used for and what it means and how it can help. And so we have to continue to educate our stakeholders on those issues as well. When it came to testing, in the early days of COVID, the testing need was not accurately anticipated. It was very slow and ineffective rollout, slow to allow for broad testing when it was good, when we did have good testing. And the network of testing depended on a community's ability to demand, receive, and handle resources. We were fighting each other for PPE and for testers, and it was just incredibly frustrating and ineffective for our community, and it ended up costing lives. Disease transmission, the way it was transmitted in COVID, meant that testing workers were at high risk, and they needed abundant special protection that was in short supply. And we had unknown risk to that extra, to those providing that extra labor force. With monkeypox, the testing need was acknowledged. The rollout may have been frustrating, but it definitely was faster. We engaged commercial labs very early, and a testing network had been established, and so we were able to utilize that. Testers were certainly at lower risk due to the route of transmission. Lab workers had prophylaxis available, and what was known about monkeypox was less frightening, so that made testing better. With vaccination, we can all applaud the unprecedented rapid development, the global cooperation within the scientific community. The rollout strategy was kind of hard to define, and it maybe felt last minute, but I believe it did go according to plan. Even though we didn't maybe like the plan, it did go according to plan. And the political climate caused a new hesitant population to arise for which we didn't anticipate and have a strategy. So for monkeypox, there was an existing vaccine, and it was in short supply, but we had a vaccine. There was a rapid implementation of a dose-sparing strategy so that there would be more vaccinations available or immunization available for those in need. And then we had much jurisdictional collaboration to deploy those vaccines. So, what we saw with competition, competing for vaccine and competing to be a hub didn't need to occur with monkeypox. So that was a success. And then prioritizing populations. So with COVID, it was a novel virus. And so we needed time to identify which would be those priority populations. Is it going to be the young? Is it going to be the old? Is it going to be the middle-aged? Is it going to be certain people with certain pre-existing conditions? The usual vulnerable populations could be predicted, but those new ones were not. And so we also, I don't think we anticipated the competing value for life of the elderly and most vulnerable and the economic strains. In monkeypox, we again had the existing vaccine that was in short supply. We had a rapid implementation of a dose-sparing strategy. As I said before, as I said before, that was with vaccine. We had the jurisdictional collaboration, and then we had acceptance of some of those competing values. And that really helped us to prioritize the populations and the messaging that was given on how to avoid getting monkeypox, even if you weren't able to get vaccine or didn't want to get vaccine, that there were other strategies that you could use. And we did not shy away from messaging that as well. So some examples of humility. We learned respect for non-health related occupations. We expanded our definition of research, as I said. We learned to respect the role of the political leader and the lens with which they must necessarily operate. We had to acknowledge that newer leaders and newer partners to public health weren't going to perform the same way as experienced leaders. And that doesn't mean that they were worse, they just were newer. And so we couldn't expect the same performance. In monkeypox, we messaged to follow local authorities and guidelines. And that was actually a great acknowledgement because that occurred. I saw that over and over. Follow your local authorities and your local guidelines. And that was something that we learned from COVID, that certain things are going to happen locally. We recognize that an election cycle will affect your messaging, but should not compromise on your truth. Enlisting community partners, and we watched the evolution of the disease to then be flexible in how we responded, and then having early colleague notification and encouragement of getting that message out was possible because of what we had learned about communicating and collaborating with during COVID, and adding partners to the table that we may not have considered valuable partners in the past. And then we had to take the wins. I remember at one point I was delivering a message and I said, it's become apparent that we can't tell COVID how we should behave. The virus will tell us what it's good and prudent to do. And I had an angry resident at one of our vaccine events, and he was getting his vaccine at the time, But he told me, yeah, I remember what you said, and ain't no virus going to tell me what I can do. However, he was sitting there next to his wife getting a vaccine so that he could go see his grandchildren. And so, you know, you take those wins, you let people say what they need to say. You know that we're going to have, as this photo shows, we're going to have vaccine and people that are going to not be in agreement with our messaging, but we take the wins and we continue to move on. So we can close our books and we can think about public health making history. We have made it, we're still living it. And what we want to do, I think, is leave a legacy. So as I said in the beginning, evaluating recent past actions and claiming lessons learned is a bit like scoring a test while you're still taking it. It's just not possible to get everything right. So even if you got all the answers correct in the first half, you are not going to pass the test because you haven't seen the second half in order to grade it. So there's this thing in college that you have that wasn't around when I was in college. And well, there's a lot of things that weren't around, like laptops and the internet and Twitter, but that's another story. So I'm referring to something called, it's called Rate My Professor. And we had something called word of mouth. And if you didn't know the mouth, then you didn't get the word. And you ended up with the professor that no one else wanted. So here's the thing. When you read those evaluations from Rate My Professor, it becomes readily apparent that the rating is subjective and it depends on the lens of the rater. So I would caution all of us not to judge graders too harshly. And remember that few of us have lived multiple lives simultaneously, and we have the view we have. It's an exercise in futility to expect others with different eyes to see and evaluate through our lens. So I challenge us to apply flexibility, open communication, to initiate collaborative efforts with new and unlikely partners, to have patience and humility in order to learn and apply lessons that leave a positive legacy for the future of public health. And that's what I have.
Thank you so much for giving this wonderful presentation, Dr. Minter. I did forget to mention that this webinar is being recorded and will be available on the TEFI website in a couple of days. You'll receive an email notification that is up and ready to view. I'm seeing, okay, so I have one question. What improvements or changes do you feel still need to happen from what has been learned and what's going on even still today?
Sure. So let's see if I can stop sharing. I actually think, yes, okay. So I think there's several things actually that we still need to learn and still need to do. We definitely need improvement on health inequities. We've highlighted how health inequities impact all facets of our society. And so we have to continue to concentrate on health inequities. We certainly, I mentioned that we are improving in the areas of data, but data disaggregation is still a huge issue, at least for us, for getting that permission to share data in a way that will help everyone and will move needles a lot faster. Another, I think, something that's come up with just even with Ebola is just understanding the testing process in itself, that there are ways that we have determined are maybe not useful for testing because we're not open to all of the different desires for a test that the public might have or that individual clinicians might need. And when we are looking at an emerging infectious disease, it's challenging to have to go through a process that doesn't allow maybe for maybe a broader view of why a test is needed, not necessarily only because the disease is absolutely pointing in that direction, but maybe there's a good reason to document a negative test. And so I think what's really nice is having collaboration that allows you to be courageous enough to get information and to push for information that you need. And we certainly, I think, saw that play out in COVID when we didn't have testing early, and monkeypox when we were starting to have permission for testing, and then we got it in the public earlier. But we're seeing, we're still seeing some of that even with Ebola. So I think that's another area where we could improve. I will say that I feel like there's a lot of legacies that we are leaving from COVID. As I said, electronic disease reporting in every state now, data modernization, that DMI initiative pushed in order to get different genomes with SARS-CoV-2, surveillance, wastewater surveillance. I mean, you couldn't, being in Houston, it just makes you just so proud, or being in the Houston region, to provide this early detection method of surveillance of wastewater for so many diseases for the future. And we take that for granted now, that rapid development of telehealth and telemedicine platforms, as well, of course, as the rapid development of the COVID-19 vaccines. So we've got a lot of great legacies to leave as well.
Okay. Another question, what training or resources do you wish that your health department had during the pandemic that is still a gap?
Yeah, so there's, I think there's a training in communication and health communication. I think that's still a gap. We're certainly taking advantage of that kind of training with our team. I think that we have tried to take advantage of a lot of the funding there to get the training and to get training for understanding different communities and how different communities receive information. So I think that's a huge gap that we are making strides to get filled.
Right. And another question we have, moving forward, what lessons learned from COVID MP will or have been implemented to address the overdose epidemic? What motivation is needed to encourage departments in the same county to collaborate?
That's a very, very good question. I think we've been focused so much on these emerging diseases that we are not necessarily focusing on emerging epidemics that aren't infectious diseases. And so I definitely believe that we have got to make sure that we continue these open conversations, collaborating across different jurisdictions, utilizing things within the region, within the state, where we have partners that have benefited from grant funding and establishing certain databases and tools to use to understand the level of impact of the opioid epidemic. We need to take advantage of that and not have to relearn all of those lessons, but take advantage of what they've learned and be able to apply it locally for our communities. But certainly that's obviously a data issue as well, making sure that we're getting good information about really what it looks like for our population.
All right, and one last question. How can public health departments do better with engaging people via social media? How do you?
Well, that's a challenging question. I think for our department, I feel so fortunate to have such a great outreach and engagement team and a communications team. One of the things that's interesting when we were going through some of the health disparities learning and sharing sessions with those of us who have gotten the community conversations on health, sessions, we talked about the fact that people are still getting information in other ways other than social media. So especially when they're making health decisions. So where we keep the discourse, we keep positive information in the public view in that social media arena, we also need to remember that it is sometimes those tried and true areas where people are making those important health decisions. So when you're going to their faith communities, or when you're going to their schools, or when you're going to community events, when you're going to places that they go every day, when you're at their grocery stores, and as you saw, they trust, people seem to trust their people they know. So I think it's really important for us to use social media maybe to amplify the use of trusted partners and lead them to those trusted partners, and then educate those trusted partners so that we can have great information provided.
All right. Well, thank you so much, Dr. Minter, for presenting today. And thank you, everyone, for joining us. And we hope to see you all in our next grand rounds in January. Everyone have a great evening. It was wonderful. Thank you.